I'm Dr. Jackie. Welcome back. I'm a child psychiatrist. I make videos on psychiatry, psychiatry training, and how mental health is portrayed in the media. If that's interesting to you, like and subscribe and join the team. So in today's video, we're going to talk about the assumptions about psychiatry, about psychiatrists, some assumptions I might have had about the field in general before I even joined, assumptions that I've found that people have about my career through either doing this YouTube channel or people just meeting me and finding out that this is what I do and asking me questions about different stereotypes or biases. When me and my friends started making this list, we realized that there were actually a lot of them. So there's going to probably be a part 1 and part 2 to this video. I'm curious if anyone else shares this concern about going into psychiatry or have had these assumptions about psychiatrists too. Number 10 is that you can trust your doctor. And just hear me out for a second. A lot of people go into their physician, maybe not trusting them very much, but there is a great amount of people that actually go in and might blindly trust their physician, especially a psychiatrist who they might kind of put on the doctor that they already kind of just know everything about them because it's inherent in their field. When someone says that they're psychoanalyzing or understanding, formulating a biopsychosocial, we have to know so many details about a person's life that it's really quite impossible to actually come to understand somebody without having all of those complexities and details. It's important for the physician to feel like they have to earn your trust, but also for you to make your doctor earn your trust. There's something about a working relationship with psychiatrists in general that maybe if you went into a different specialist, they could diagnose and understand something that you're presenting with within that visit. It is really difficult to do that in psychiatry without really getting to know a person and getting a lot of details that might take multiple visits. Of course, we can go by criteria, and so if you want to be algorithmic in nature, you can pull out a book and you can read down the list and you can complete rating scales and measures and say, yeah, you meet criteria for this. But how that manifests in a patient's life and how it actually functionally impairs them is going to be so random. You cannot actually make a meaningful impact outside of maybe providing a diagnosis without really sitting with the person that's in front of you and understanding what their life looks like day to day and who's important and what they want out of their life. So it's really important to not put that pressure on the doctor and also you when you're trying to make these kinds of meaningful, sustainable changes in your life outside of maybe getting an evaluation for a diagnosis. The second layer to that is there's definitely a power differential there because you're going to see an expert and you expect them to know all the answers to your questions. No one knows you better than you. Part of their job is to help you actually facilitate your understanding of yourself better. I think that's the trademark of a really good psychiatrist, is that you walk out of their office or walk away from the session and feel like you have a better understanding of who you are and what you want out of your life. Where it gets tricky is that you might trust them completely and not necessarily feel like you can advocate for yourself or that you can question their decisions or their statements. They're human too, and so everything that they say is not necessarily written in stone. You can question it and say, I don't actually think I believe that. Can you help me understand why you would say something like that? And that kind of working relationship is really important when it comes to a doctor-patient relationship. Number 9 is that our personality is flat. I'd like to think that I'm trying to combat that. I put myself on camera on YouTube very publicly to show you that I also do not look like maybe what people think psychiatrists should look like or would look like. And so we come in many different packages in different sizes and shapes and colors. I think our personalities can vary widely too. When I was going through training, I think what I recommend to a lot of people is finding your tribe. And what I mean by that is when I was around child psychiatrists, we had a lot of similarities and I could just hang out with them and there were things that we could talk about that felt very similar and obviously geek out about the same things and oftentimes that was kind of about how to help children and families in a very meaningful way, in a way that we felt skilled in. So yeah, I'd like to think that our personalities aren't flat. Historically, that might actually come from Freud times, where people would say that when in training you had to have like a very blank slate because it would impact your relationship with the patient, that you'd be in like this white room and the patient actually couldn't look at you. You'd have to sit in a position where they couldn't see where you were because they were concerned that that would impact your relationship with them. That is very much not how psychiatry, modern psychiatry, is practiced at all. And there are times when you want to make sure that you're not feeling like that disconnected. If you're not necessarily connecting with your physician or psychiatrist, or you as a psychiatrist are not necessarily actually connecting with your patient, then really exploring that during supervision, and also kind of talking about whether it's the right fit. And of course, like, relationships grow and morph through time. So you want to, again, work through these kinds of things. Like, it's not something that's not overcomable, but it might impact treatment. And so you want to kind of explore that and at least understand where that might be coming from. The 8th assumption on my list is that we only do meds. We only believe meds are going to work and that you have to be on meds forever. This is also closely linked to, if you see us, we're definitely going to put you on medications. That's definitely an assumption and not true at all. Especially in child psychiatry, medications, but also in adult psychiatry, medications are used judiciously and should be used judiciously. There have been a lot of moments or times where I have had patients walk into my office and I see their medication list historically, and also what they might be on now or more recently. They are on quite a long list of medications, and that we call polypharmacy. And there has been a big movement to undo that. And I want to put a disclaimer that I think every provider and prescriber wants to do what's right for their patient. They want to give their patient something that actually will help, especially when people are coming to you really sick and struggling and suffering and in distress. And that might translate into maybe prescribing more medications than we have actual evidence for, because they feel like that is the thing that they can do to be helpful. And that is not always the answer, and understanding that and understanding why you might be pulled to overprescribe is something that the provider has to work through. That's contingent on the provider. That's not for the patient to understand, because they are going to just be a good patient and take the medication as prescribed. And so not to be threatened by a patient that is actually saying, like, I'm actually on too many meds and none of them really help or work. It's on us to say, I actually think that this is like the best that I can do. Maybe I'm not the right doctor for you. I honestly feel like that takes a lot of courage to say, and a lot of your ego has to stay at the door that you're not good enough for that patient, but it has to be something that you take ownership of and are responsible for, because these are people's lives, people's bodies, and they're trusting you. How I explain the use of medications for my patients and families is that if we are struggling to do the work in therapy because our symptoms are just too high, so say like it's dialed up to an 11, and so you show up every week like you really should, and you're motivated to do the work in therapy, but your anxiety, your depression, everything is just too high to be able to tolerate the work, because therapy is hard work, then we might use the medication to kind of silence the symptoms, bring it down maybe to 11, maybe to like an 8 or 7 or 6, something a little bit more manageable, so that you can actually do the work. Because really that's what medication is created to do, is to make the symptoms be not so severe, make it maybe moderate to mild, but that does not replace therapy. And I tell the families and the kids all the time that medications are not going to teach you skills. They're not going to change patterns of behavior. They're going to just change the symptom volume, and so that we can hear the therapist and create coping skills and work through things. Because of that, you might not always be on medication. You might use it also judiciously in your life, because life will throw you many lemons. You might not need to always be on medications for the rest of your life, or if you feel like it is helpful, you could always stay on the medications, but it might not necessarily need the same dose that you always needed. All right, number 7 is that we do not practice therapy, we don't understand therapy, we don't do therapy, we're incapable of therapy. I think it's important to know that training is very different for each psychiatrist. And so depending on what symptomatology they might niche themselves into once they actually even join psychiatry, it will impact what their knowledge of every different type of therapy is, or at least the depth of their understanding of a different type of therapy. Our job as psychiatrists is often to make a referral, recommend certain types of therapy. And so of course, you wouldn't be able to make a recommendation for a certain type of therapy for your patient that's coming to see you without understanding, at least superficially, what kind of therapy has the most evidence for what they're struggling with. Depending on what setting you might find yourself working in, you may or may not have the luxury of doing a certain type of therapy to fidelity. And what I mean by that is a lot of types of therapy are manualized because that's how we prove in terms of evidence that it is impactful for a certain type of thing. We're not so rigid to only implement therapies with worksheets and at a certain timeline. But there is rhyme and reason types of therapy. I think a lot of people think that therapy is just one type of therapy where you might walk in and you just talk about what happened during the week, what happened since the last session, and you have a sounding board. That is what we call specifically supportive therapy. There are different types of therapy that I've talked about before on this channel, like cognitive behavioral therapy, which has the most evidence when it comes to something like anxiety. Cognitive behavioral therapy is specifically focusing on what types of thoughts cause a certain emotion and then how our behaviors are kind of tied into that. And so that has a specific type of framework that you're really working around. Likewise, other types of therapy have different frameworks to treat different illnesses. And so you want to understand that as a psychiatrist so that you can make appropriate referrals and recommendations for your patients. Final one for this video is that people assume that I'm analyzing them all the time. If I could tell you the amount of effort that it actually takes me to psychoanalyze some of my patients, you would realize that I would need hours of your time and you would need to answer an overabundance of questions about your childhood, about your day-to-day life, how you feel about so many different things. The devil is in the details when it comes to analyzing, and so I wouldn't be able to just analyze you from maybe like a dinner conversation. Your experience from one isolated event is not going to really tell me much versus maybe experiencing different patterns over and over again and how you might perceive that. That might help me understand how you might walk through life. But analyzing somebody takes a lot of work and a lot of time, and so I just want to squash that assumption that you might have. Therapists and psychiatrists really can't psychoanalyze you from just hanging out with you, even if they wanted to. Thanks for watching this video, and I will see you at the next one where I talk about my top 5 assumptions that people have about psychiatry and psychiatrists. Trust me, there are more, and so there had to be 2 parts of this. If you want to reach me, you can always leave a comment under any of my videos. I try my best to answer each and every one of them, and also message me on my Instagram, Dr. Jackie, and I'd love to carry on the conversation through there. Again, please be respectful when you're posting comments about yourself and others or this career in general. Anything that furthers the stigma is going to be deleted respectfully and kindly. I love seeing all of you support each other in the comments. It's just so wonderful, the community that we're continuing to build, and I will see you at the next video. Have a great week.